just wanted to say what a pleasure it is to have you here. You speak directly, your facts are in order, and I think your message is clear. Mr. Waxman, we welcome you. We're delighted that you're here. You're a real leader in this issue, and please proceed as you feel most comfortable.
Thank you very much, Madam Chair, members of the Budget Committee. Let me begin by thanking you for holding this hearing. You've shown real leadership on the problem of the AIDS epidemic and what it poses to the nation, and I hope this year's budget we can begin to address some of these issues that are most pressing. Over the past 9 years, the country has gone through cycles of AIDS awareness, from ignorance to hysteria to complacency. We have gone from a time when no one knew of AIDS to a time when everyone was terrified of it, to a time when everyone knows about it and most people are seemingly unconcerned. This complacency is dangerous for public health policy on infection and treatment, but such complacency is particularly dangerous for budget policy. We cannot shortchange the epidemic. It is threatening the lives of hundreds of thousands of Americans. It's threatening the solvency of our public health system. It's threatening the adequacy of health care services to all Americans, infected and uninfected. The President's budget is constructed as if these costs won't happen and as if the worst of the epidemic is over. It is not. The worst is yet to come. And this budget doesn't provide for those sensible activities which could help us reduce the spread, development, and impact of this disease. There have been 120,000 cases of AIDS in the last 8 years. The health care system in urban areas has been stretched to the breaking point. The Public Health Service estimates that there are 1 million infected Americans and that more than half of them have severely compromised immune systems already. Over the past 2 years, the major research advances in AIDS have been the development of drugs that will prevent or slow the development of an HIV infection into diseases that require hospitalization. With such treatments, people live longer, healthier, more productive lives, and hospitals have fewer patients and Medicaid fewer costs. Right now, however, although poor people with full-blown AIDS can qualify for Medicaid assistance, poor people who are infected and have a deteriorating immune system, but who don't yet have full-blown AIDS, cannot qualify. That means that Medicaid will pay when people need expensive inpatient care to treat pneumonia, but won't pay when they need drugs to prevent pneumonia. It's a crazy catch-22 for Medicaid and for the patient. Rather than keep people productive, we let them deteriorate. It's stupid and it's expensive. In addition to addressing this catch-22 of early intervention, we must also turn our attention to the hospitals that are caring for AIDS patients, and Congressman Schumer has addressed that. Many hospitals are overflowing and on the edge now, and without some help, they'll just go bankrupt. But Medicaid does not begin to pay for the real costs of the epidemic to the hospitals that are treating AIDS patients. While every institution expects the average Medicaid patient to cost it money, AIDS patients cost them a lot of money. According to a 1987 survey, hospitals lost an average of $136 per day under Medicaid on AIDS patients. This is about 5 times the average loss that hospitals reported that year under Medicaid on their average medical surgical patient. There are hospitals all over the country that cannot easily make up the losses on Medicaid patients by raising charges to private patients. And these are not hospitals that these communities can afford to lose. While Medicaid may not be able to do much to improve the situation of these hospitals, we cannot allow inadequate Medicaid payments to make their problems worse. In addition to these Medicaid improvements, we must also pursue discretionary spending to provide emergency assistance to some of the areas of the nation that are hardest hit by the epidemic's past 9 years and will be even more stretched to meet the demands of the coming cases. It's becoming clear that many of the voluntary agencies are not able to cope with the scale of the epidemic in the 90s. Finally, we must pursue a large-scale program of prevention of infection among the uninfected and prevention of disease among those already infected. Such a program involves federal grants to states and clinics for counseling, testing, diagnostics, and early intervention drugs. Along with many members of this committee, I've introduced H.R. 4080 the Medicaid AIDS and HIV amendments to make early intervention drugs available and to effect hospital payment changes in Medicaid. I will also be introducing other legislation on AIDS prevention and emergency assistance. Clearly, there is much more that we must do, and I know, Madam Chairwoman and Mr. Panetta and members of the Budget Committee, with the kind of deficits that we have, you'd rather not have us come here and press you for more Medicaid spending, more discretionary spending to deal with the AIDS problem. We really have no choice. Unless we pay for the early intervention drugs for Medicaid patients, we're clearly going to pay through Medicaid for their hospitalization. Unless we give a higher reimbursement to those hospitals that take care of Medicaid patients, we're going to lose those hospitals. There's no other way around this because Medicaid is becoming the payer for health care services for AIDS patients, especially as they lose their private insurance. We're also trying to make available through Medicaid the opportunity for states to use Medicaid to help pay for the COBRA extension of health insurance that will bridge the gap between those who lose their insurance till the time when they're so disabled that they end up on Medicare, if they can live that long. But Medicaid, according to many states, should be available to them at their option to cover the care for those patients that would otherwise lose their insurance in its entirety. We're going to need Medicaid money. We're going to need discretionary spending. And the discretionary spending for emergency care for those areas hard hit. We're going to need discretionary money for a bill that we're working on and soon will introduce for testing, counseling, and early intervention drugs. We're going to need more money as well for research. We must make a start. If we don't, our whole public health care system may be flooded with sickness, death, and bad debt. The communities it serves will be devastated. The enormity of the problem is only dawning on most people now, many of whom thought the epidemic was waning. The President's budget does not begin to meet the needs. This committee must do so. I thank you for this chance to
Well, thank you very much. I would say that our two witnesses really have been in the cutting edge of these issues ever since I came. Congressman Waxman was right there in the leadership, and when Congresswoman Pelosi arrived with a fresh energy, she hasn't stopped in really leading the way. And I think it's very interesting, both of your testimonies side by side just go hand in glove, because what Congresswoman Pelosi did was to show us the shortcomings in the Bush budget, and what you did is to kind of give direction as to what we can do specifically. So without, I don't think you collaborated, you have presented us with an excellent comprehensive view. I would like at this point to just place Mr. Weiss's testimony into the record so that it can follow immediately after these. And I would like to ask you, Mr. Waxman, a question on, give us an example of how the system is failing. A case that comes into a heavily impacted hospital, how that hospital loses the dollars, if you can, to just bring it down to a case-specific basis, if you can, for us.
A patient has AIDS and requires hospitalization. We weren't fortunate enough to reach that patient to discover the infection before the infection developed AIDS and use some of these early intervention drugs. Patient requiring hospitalization goes to a hospital. If that patient doesn't have private insurance, he's going to go to a hospital that will take him. He's covered under Medicaid because he's disabled. By the way, if he were only infected and were poor, he wouldn't get help from Medicaid for those drugs because he's not disabled, because the tie-in is you're either aged, blind, disabled, or dependent children, not just poor. Poor doesn't do it. So the Medicaid law says you've got to be disabled. Well, he's clearly disabled if he's got AIDS and requires hospitalization. Now Medicaid will pay the bill. He'll go to a hospital that will take Medicaid patients, and Medicaid will pay the hospital much less than it costs the hospital to care for that patient. What are the hospitals that take these kinds of patients? Well, they're most likely public hospitals or hospitals with a tremendous amount of low-income patient populations, not just AIDS, but poor people with other medical problems, also being reimbursed by Medicaid, also being reimbursed less than what the cost is to the hospital. hospitals that have a high share of low-income patients don't have the ability to shift some of the costs that are not met by Medicaid onto private pay patients or privately insured patients, because by and large they don't have privately insured patients. So the hospitals are hanging on, hoping that they can shift things back and forth to the point where at some clearly discernible event they're going to find that they're just running out of money to take care of any of the patients. And that's the case with many urban hospitals that are wondering whether they can even keep their doors open to anyone.
So the population in these hospitals is such that they just don't pay their way, and they can't shift to the people who have insurance, because those people aren't at those hospitals. Have you discussed this with Mr. Stark? The problem of these hospitals with Mr. Stark?
I haven't discussed it with him, but these wouldn't be Medicare patients. These are until 36 months after they are hit with AIDS, would they then be eligible to be on Medicare as SSI. For the most part,
as opposed to Medicaid.
Right. For the most part, these patients haven't lived long enough to get Medicare, so they're on Medicaid.
Right.
And I'm happy to talk to Mr. Stark and others, but Mr. Dingell has the jurisdiction over the Medicaid area.
So the Medicare doesn't kick in until 36 months.
Right. But Medicaid becomes the payer once that patient becomes disabled. And our committee, which has jurisdiction over Medicaid, can't move unless your committee provides the funds that will allow us to pay for early intervention drugs, pay a higher reimbursement rate to those hospitals that take Medicaid patients, and thirdly, allow the states at their option to use Medicaid dollars to cover people to have their private insurance available to them.
The reason I mentioned our colleague, Mr. Stark, who's a dear friend of both of ours, is that I'm concerned about his feelings about hospitals today, and I think it's important that we make the point that there are some hospitals that are in serious trouble. That was my point.
Well, it's a good point, and he's mindful of it, because in the Medicare program, we've tried to have a higher reimbursement for Medicare patients for those hospitals that have a higher disproportionate share of low-income Medicare cases. So on Medicare, we try to give a little higher reimbursement. On Medicaid, many of these hospitals don't even have that much Medicare. On Medicaid, they're even in dire
I understand.
straits.
Well, thank you very much. Ms. Pelosi, I have one quick question for you, then I'll turn it over to the rest of my colleagues. In San Francisco, we've had what has become known as a San Francisco model, and we've been able to do some very cost-effective things to avoid the high cost of in-hospitalization. Are we at a crisis point now in San Francisco? In other words, can we continue this if we don't get impact aid, in your opinion?
No, I do not, Madam Chair. San Francisco has been a model on how to treat patients in a casework manner. That is, maybe they a person with AIDS shouldn't be in the hospital, and we like to make that person as comfortable as possible, if that is at home or whatever. So we have striven for what is best for the patient and what is best for the budget. And frequently they are the same thing. People do not have to pay the high cost of going to the hospital just because they have AIDS. So we have sort of in fact, there is some legislation for this consortium approach to caring for people with AIDS. But frankly, many of our people are burning out. This issue has been with us for a while in San Francisco. The caseload of people not becoming infected with the HIV in the gay community, that has been curtailed, but the people who had HIV, who are now contracting opportunistic diseases associated with the HIV, the caseload is increasing, and we simply do not have the private resources to continue to deal with the number of cases at hand. So we will need some federal participation. Absolutely, as you mentioned, the impact aid, as Chairman Waxman and you have both mentioned, the early intervention, very important to us. But impact aid is something that we are looking to and hope that, which is in the interest of the U.S. taxpayer as well as in the interest of the people with AIDS.
Thank you. Mr. Chairman.
Thank you very much. And thanks to both of you for the testimony you provided. As always, it's a very important issue for us to confront, and when the administration doesn't put a lot of money into it, then the pressure comes on us to try to face up to that responsibility. And I recognize the leadership that both of you have provided on this issue. Let me ask, one of the criticisms that I have heard is that doubling the amount of money, not on the Medicaid issue, Henry, but on the other side, which is basically doubling the amount of money that would flow to the Public Health Service and research, is questionable because of the lack of resources there to basically make use of that kind of money. The lack of personnel there, the lack of adequate scientists, researchers, et cetera, that even if you doubled the money, it's not going to be used effectively. And I guess I'd be interested in your comment on that by, number one, are the funds that are currently being placed there. I think the number that I am working off the 90 resolution is 1.5 was what 1.586 is what the Appropriations Committee provided at the current level, so it's about 1.6. Is that being effectively used right now? And you know, if we double that number, would it be effectively used by the Public Health Service?
Mrs. Pelosi contacted the researchers and asked them what they thought they needed, and they indicated this money could be needed and used constructively. The question of resources, when we have a ceiling on full-time equivalent employees at NIH, becomes a difficult one, and I think we need to eliminate that ceiling so that we can use that money effectively. If we do eliminate that ceiling, that money can be used for research, and I take it face value the comments of the researchers as to what they think they need.
May I address that, Mr.
Sure.
Chairman, for a moment? Further to what Mr. Chairman Waxman said, last year when Mr. Darman was before our GovOps committee, he said that I asked him the question, who are the scientists at OMB who are second-guessing the administration's own scientists, doctors, and health professionals? Who down there knows more about the administration's own medical professionals about what is necessary in the fight against AIDS that gives you the justification to cut these requests? And he said two things. First, he said it wasn't his budget, it was the Reagan budget, and give him a chance until next year. But more poignantly, more to the point, he said, oh, everybody knows that everybody pads their request. They know they're going to get cut back. And I think that, and then I called some of the scientists after that, specifically spoke to Dr. Fauci at some length then and since then. Basically, what the scientists are telling us, that quite to the contrary, they are not padding their budget knowing they're going to get cut back because of what Ms. Taylor testified to and what Mr. Waxman referred to earlier, the competition for the dollar and biomedical research, people and other kinds of research that goes into finding a cure or a vaccine. Many people are giving their most responsible, defensible number. They need more. But if they ask for as much as they think they really need, then there might be some reaction to that request. So they have a realistic figure, which is in no way padded, but which is below which would be irresponsible to ask for. That's what I heard from the scientist. So as far as I can tell from Mr. Darman, there are no scientists at OMB better qualified to determine the needs for AIDS than the scientists in the administration. But his response was everybody knows they pad it and nobody expects to get what they ask for.
Thank you very much. Appreciate, again, both of your testimonies, and you can be assured that the committee will respond to this issue.
Thank you, Mr. Chairman. With the indulgence of the committee, if you could hold off on questions, Mayor Dinkins has arrived along with Mr. Weiss. So what I would like to do is thank Mr. Waxman and Mrs. Pelosi, of course, for their leadership. We will work very closely with you. You will be called on, and we'll do the very best we can to meet all of the needs that you've outlined, and I certainly share and would associate myself with your requests. And thank you very much. And we will bring in Mayor Dinkins. I will also ask the second panel on impact aid to take their seats. Mr. Sweeney, Dr. June Osborne, if you would take your seats up at the witness table, and then you will be joined by Mr. Dinkins and Mr. Weiss. The committee will resume its hearings. We are just delighted Mr. Mayor,